Hello, my name is Ronald Torres, and this is the individual webcam case study for NURS5329 Adult Gerontology Acute and Critical Illness 1. I have here a 68-year-old male. His chief complaint is frequent falls, general weakness, and recent admission with bacteremia. His HPI is as follows. He is a 68-year-old male with prior medical history of hypertension, CHF, type 2 diabetes, high cholesterol, obstructive sleep apnea, hypothyroidism, bicuspid valve abnormality, Pickwickian syndrome, and he has a BMI of 71. Patient was admitted to the telemetry floor for E. coli and bacteremia with general weakness with frequent falls. Patient was actually recently discharged 3 days before this event for CHF exacerbation, E. coli, UTI, but refused rehabilitation and SNF. On that visit, the patient was discharged with a Foley catheter, told to follow up with the urologist, and to take the medications, antibiotics as prescribed, and he was not compliant. Blood cultures on the previous admission showed positive for E. coli, but no treatment was given, once again because the patient was not compliant. What makes this case particularly interesting is upon evaluation, on arrival, 0700, with my preceptor, hospitalist, the RN staff and telemetry had called us because the patient was in SVT, sinus tachycardia, and he was seen with a heart rate of 143. So we had arrived, immediately went straight into that telemetry floor. We had informed the RN staff to get a stat EKG, get a stat troponin, and call the cardiologist. When we arrived to the room, the patient was asymptomatic, denied chest pain, denied shortness of breath, denied fevers, denied chills, denied body aches, denied nausea, denied vomiting, denied diarrhea. He did not show, he was positive for generalized weakness and fatigue and lower back pain bilaterally. Cardiologist had informed RN staff that with this patient and his prior history with this patient, he would not be compliant, and just to proceed with ACLS guidelines, and hung up. So the hospitalist and I, we took it upon ourselves to proceed with the patient, and we told RN staff to get amiodarone 300 milligrams. 300 milligrams to be given IV over 10 minutes. Static EKG was performed, showed SVT with right bundle branch block, was throwing premature atrial contractions as well. Laboratory had been received into the room. I gave the orders to the troponin, had already been run as the bedside, but wasn't a serum. So ran the troponin with the series to done at 90 minutes and 120 minutes for the next 6 hours. And then 90 minutes, 120 minutes, and then at the 6 hour mark. And we're going to continue to trend those. Told her to run a CBC, a CMP, a BNP, and magnesium and phosphorus laboratory, as well as a lactic acidosis. At that time, my preceptor had also advised the RN staff to get lidocaine 100 milligrams IV, which is given to the patient. And the patient's heart rate decreased to 120s, continued with showing asymptomatic signs and symptoms. Second dose of amiodarone 150 milligrams IV push was given per my order. The patient continued with HPI, stated he was admitted originally because he fell and was having difficulty getting back up. He had called EMS, was taken to the ED. He was actually a downgrade from CVICU, the ICU, to the telemetry floor, which is the first day we received him. It was a heart-to-heart moment with the patient when my hospitalist had to discuss with him what was his plan, what was his goal. We had discussed with him, you refused treatment and sniff care on the previous visit and the current visit. What was his end game? At that point, the patient said he wanted palliative and comfort care. He didn't want any heroic measures taken for him. His code status is DNR. Allergies is no known drug allergies. Surgical history consists of the cholecystectomy and tonsillectomy. Social history did not need smoking, any drinking, any recreational drugs. His family history was non-relevant to the case. The psychosocial, he was A single 68-year-old male, uh, no children, no previous spouse, parents have already been deceased. He had no care for him. When he got when he got discharged, he was discharged to home, which is non-compliant. He said that he was bedridden all his time when he was at home, even when he was at hospital, which is another reason to believe where he discussed that lower back pain was due to. Review system, 12-point review system performed pertinent positive negatives per the HPI as discussed. On physical exam, his vital signs as follows: 97.8, temperature, that was oral, heart rate at this time was 134, respiratory 22, a blood pressure 115/53, SpO4 94%, on 4 leading nasal and 5 out of 10 aching, dull, bilateral lower back pain. Constitutional, he was sitting in bed, awake and in distress. HEENT is normal cephalic, atraumatic, pupils E equal, round, reactive, and accommodating to light. His hearing was grossly intact. His neck was supple. No thyromegaly, no JVD. Cardiovascular-wise, S1, S2 was audible. His heart rate was in the 130s, 120s. There were no murmurs. There were no gallops. There was no rubs. There was trace edema, bilateral lower extremities. Pulmonary, there was diminished bilateral bases. Supplemental oxygen was given. It was in place. But there was no wheezing. There was no rhonchi. There was no rails. Abdomen, his abdomen was normal to all quadrants, soft, round. Abdomen was rounded due to obesity, BMI of 71. There was no tenderness upon palpation. Extremities, the range of motions were normal to all extremities, and as we discussed, trace peripheral edema to bilateral lower extremities. Peripheral pulses were normal though, equal, and to all extremities. There was no clubbing, there was no cyanosis. Genitourinary, there was no CVA tenderness. He was voiding without difficulty with indwelling urine catheter in place. His eyes and nose, he showed a positive of 400 milliliters. And he was given normal saline at 80 mil per hour throughout the night. It was a Q12 order, and that was his, I believe, his second bag. There was no dysuria, no frequency. Skin, there was no, it was warm, no rashes, it was dry and intact. Neurologically, he was awake, he was alert, he was following commands to upper and lower extremities. Psychologically, he was anxious, but he was cooperative. His labs, as well, they came back. White blood cell count was 12.71, hemoglobin 13.0, hematocrit 41.4, platelets 292, sodium 140, potassium 3.5, chloride 101, CO2 281, 28.1, BUN of 33, and a creatinine of 1.48. Glucose 120. Troponin had showed a 0.03. Lactic acidosis was negative. Previous lactic acidosis that was ran in CVICU was also negative along with procalcitonin. So we didn't believe this was a sepsis problem. I believe this was a cardiovascular issue. He was not hypotensive throughout the physical exam and our time with him. His urinalysis did show leukocyte esterase 3+. WBCs were increased at 32, and there was no hematuria. Echocardiogram that was done previously showed ejection fraction 35%. His chest X-ray that was done previously, and that was 2 days prior, showed no acute cardiopulmonary process. We did also run a repeat chest X-ray, but that was routine, not stat. Since the patient had no complaints of chest pain and no pulmonary shortness of breath or any kind of difficulties with his respiratory system. Patient was already on amiodarone 200 milligrams PO daily, metoprolol 25 milligrams PO BID, some pravastatin 40 milligrams PO daily, levothyroxine 112 mics PO daily. He was on aspirin 81 milligrams PO daily, and oxyparin 1 milligram per kilogram subcutaneously daily, and ceftriaxone to cover for the E. coli 1,000 milligrams IV daily. Our plan for him, assessment and plan, was possible E. coli bacteremia. He's already admitted to telemetry, continued monitoring. Blood cultures were pending. Urine cultures have been ordered, and E. coli been recognized. No resistance. He was on ceftriaxone 1,000 milligrams IV daily. CBC, C&P labs were to be done daily. Consultation with infectious disease was ordered, and following Appreciate the recommendations. Now the further recommendations. IV fluids were given for this patient, normal saline at 80 ml per hour. Hypertension was another diagnosis for him. Monitor controlled WBPs, hydrolysis, and PRN was ready for the patient in case he needed it. Resume the home medications, which he was doing, and compliant in hospital. Generalized weakness, he was on a bed alarm. Physical therapy and occupational therapy evaluations were placed. Case management was also following based on the situation of living alone. See if we can get him a provider that was not given to him on the prior discharge. Some healthcare provider that can come and monitor and check him from time to time. Hypothyroidism to evaluate the TSH, resume home medications. His fifth diagnosis was CHF with ejection fraction, left ventricular ejection fraction 35%. Telemetry to monitor, repeat the BNP. Echocardiogram had been ordered and resulted already. He was on strict I's and O's. So we were giving him normal saline for the Q12 hours for the next 24 hours. So the bag that he was on was going to be his last. And the concern was just we were thinking he was getting dry, and concerned that he wasn't hypotensive with us, but his systolics were trending in the hundreds, 90s. Didn't show true sepsis, once again, because he was afebrile, pelvic calcitonin was negative, lactic acidosis. So we had kept him on a 2,000 milliliter strict diet for fluid intake, and then we're monitoring him with his fluid for the next 24 hours. Cardiologist consultation had been ordered and followed. We appreciate their recommendations. Nothing further. Atrial fibrillation. Also, we were concerned with our previous history. He's had as well. He was on the enoxaparin with a 1 milligram per kilogram, subcutaneous daily. The cardiologist consult had been ordered, and he was telemetry to monitor. The Pickwickian syndrome. Respiratory therapist to assess and evaluate continuous pulse oximeter. He used the 4 liters in his account periodically, but mostly at night. Intermittently, he used it throughout the day. Stress ulcers and DVT prophylaxis were in place. All precautions in place. We informed the patient the plan of care, told him the treatment options for high heart rate, but he refused anything further than what we had given him. Given him lidocaine 100 milligrams IV, amiodarone 300 milligrams once, and then 150 milligrams second time. He requested at that time, he had changed his mind from being a full code to DNR. We explained what that meant. He fully understood, and we explained the palliative care that we're going to provide for him. We gave him 4 milligrams of morphine at that time, Q4 PRN for the patient. Cardiologist was called and informed of our findings in the AM. Cardiologist made the same recommendations, confirmed our recommendations that we had made. He also had been recommended putting him on a lidocaine drill. Patient had no family to call and made all his decisions out of his own volition. This is a good case. It fit the criteria for acute care because it was recent for me, and I was familiar with ACLS guidelines, and we immediately saw to it for this patient. Thank you.